Good afternoon. It's a bright Monday, and we are on the program Healthy Living. I am Adesuwa Osauwagie. Today on Healthy Living, I want to urge you to sit tight and, relax and watch this program from beginning to the end, because we're going to bring you something very interesting. And this is one aspect of medicine, or let's say one aspect of illness or disease that people don't really want to talk about. Maybe because of stigmatization, probably because they do not know what this disease is all about, or sometimes, like the usual African way, they label it witchcraft or something in that category. And sufferers, if they are not careful, will fall into some trouble, and there will be a mob action. And I also want to thank this special person that brought this topic to mind. We'll talk about her later and thank her later for this topic. We're going to look at dementia. What is dementia? What are the signs and symptoms? How does it affect somebody? Who does it affect? And when it comes on, what is that person supposed to do? What about the caregivers? What's their role? Family members, what are they supposed to do? Are they to leave this person to his or her fate, or take care of the person? Is it curable? Is it manageable? What is dementia? How do we go about it? That is what we're going to be looking at today on the program. And of course, you have a chance to call in. 052290-573 is the number to call us with. But we'll just talk about this disease for a while, then we'll start taking your calls. Join me, people, as I make welcome Iyom Josephine Aneni Esquire. She is President, Women Foundation of Nigeria, and as well as founder, president, Alzheimer's Disease Foundation. She's very passionate and active in the promotion of awareness of dementia and Alzheimer's disease, and the protection of the rights of the elderly in Nigerian communities. And that's what a lot of persons don't care about. Some people don't even care about the elderly ones. Most times you see them on the street roaming around with nobody caring for them. It's a pleasure to have you on the program.
Thank you.
All right, sat beside her is Dr. Mary Ehimegbai. She's a psychiatrist. It's nice to have you join us, doctor. She's also very active and passionate about people who are suffering from this disease called dementia. And we're going to talk straight. So, ladies, I'm very happy to have you in the studio. Now, let me start with you, Dr. Ehimegbai. As a psychiatrist, what is dementia?
Well, good day, viewers. Dementia is an acquired global impairment in intellect, memory, personality of the sufferer. Without impairments in consciousness, because actually it affects the brain, but the people are conscious, and is severe enough to cause impairment in social and occupational functioning.
Okay.
That is basically what dementia is.
What are the signs and symptoms?
Oh, signs and symptoms of dementia. There are a myriad of them, quite a number of them, because dementia is an illness that affects people in different domains. You have what we call neurocognitive symptoms. We have what we call behavioral symptoms, psychological symptoms, symptoms that have to do with affectation of activities of daily living.
Okay.
So that's why I said we have quite a number of them. Amongst the symptoms, we have memory problems, forgetfulness. Yes, normally the elderly, they forget, but this kind of forgetfulness is beyond the ordinary. It's not what is expected for their age. So you have memory problems, you have emotional issues, you have issues with depression, irritability, outburst of aggression. They have language problems. Actually, words don't make meaning. They find it difficult to find words to attach to objects. They are unable to construct simple sentences, especially when it gets to the late stage. We have problems with what we call executive functioning, ability to think, ability to reason, to plan and execute. They have problems with that. Sometimes they also have psychotic symptoms, visual hallucinations. They begin to see things that others are not seeing in clear consciousness. And that's why they say, oh, is Papa a witch, is Mama a witch, and all of that. And you find that they have what we call delusions. Because of their state. Sometimes because of forgetfulness, what they keep, they are unable to realize that they actually kept such. And at the same time, they'll be looking for it and saying maybe other persons stole their money, or maybe some persons are against them. So they have what we call all these paranoid delusions. They have behavioral problems, you know, problems with wandering, inability to know their way around. Social conventions, they neglect it. They actually do not know the difference between the outside and the inside. What about activities of daily living? They have problems with activities of daily living, to self-care, personal hygiene, feeding, eating, just minor activities, you know, that we need to do on a daily basis. They have problems with them. So I said before, there are myriad of them, so that those are some of the signs and symptoms.
So what's the age range? What age does this occur?
Actually, we have different types of dementia,
yes,
and that's what we define the age.
Okay.
For some, from the age of 55 upwards. For some, like the one that is caused by what we call Huntington's disease, it can occur in a child.
Okay.
But we usually have them from 45 years to any time.
Okay.
Yes.
All right, thank you, Dr. Mary. Let me come to you now, Josephine Aneni. You are a woman who is so passionate about people living with this disease. You even have a foundation. Now tell us, what's your experience with this set of people?
Well, my interest was ignited when I had a personal experience of dementia.
Okay.
In fact, a particular form of dementia, which is the Alzheimer's disease,
okay,
form of dementia. And when, you know, I saw it, I didn't know, I had never heard about it. I didn't know what it was.
What it was.
And it was difficult finding anybody around me who could tell me what it was. I had to start reading and looking for doctors, psychiatrists, everybody. And I discovered that, wow, this is a condition that I have seen before. And many people have seen, but we didn't know the name or what it was. Like doctor said, you know, there are some manifestations that will make people think it is madness or witchcraft. Or maybe Papa or Mama is now a witch. And of course, you know, they said, somebody said that in the Bible, they say, suffer a witch not to live.
Not to live.
So what do? They want to kill
mob action against
mob
the
action,
person.
like you said, against that person. I want to kill that person. So I remembered in the past that I had witnessed, you know, that kind of abuse and treatment due to lack of knowledge. And I said, no, we must let everybody hear about it. And of course, I also remembered that a lot of people that I know had it, you know, had people who were affected, and they just hid them away, you know, in their boys' quarters or in a back room. And
because of stigmatization.
Because of stigmatization. Because they didn't want people to think that this is in their line, you know, in their family.
Okay.
It would affect their girls from getting married or whatever. So people hide it. So there was a lot of denial and a lot of, you know, denying it. And then, of course, you know, not going where they should go. Because when you see those signs there, your first port of call should be your family doctor. Then the doctor will diagnose it and say, yes, I'll call a psychiatrist, I'll call a neurologist, refer you, you know, give you a referral to a psychiatrist or a neurologist, because these are more specialized in that area than an ordinary family doctor. And then they know what to do. They know how to follow the course of the disease and how to treat, how to, you know, what to do, you know, professionally. And so I said I must be talking. I have to be a loud voice talking about it.
So how have you been relating with people who have dementia?
With people who have dementia is because I now know what it is. Every case, you know, when you say with people who have dementia, it looks as if there's a lot of it. No, it's one size fits all. Everybody's dementia is different from the other person. So the way I would deal or relate with A with dementia, maybe different from the way I would relate and deal with B with dementia. There is no one-size-fits-all recommendation. So, but there are general symptoms, general behavioral symptoms that you will find that is general. So those ones, we can talk about those ones. So if you find somebody who has dementia and they are confused, you do not argue with them. Don't try to argue with them because it will not make sense anyway. So what you want to do is to make that person trust you, not be afraid of you. You know, don't be confrontational with that person. Don't, you know, touch the person gently. Hold the person. They still have feelings. They still have emotions, even though they've lost cognition of time and space and where they are and things like that. But they still know when you love them. They also know when you are abusing them. They may not be able to express it. They may not be able to say what it is. And in trying to express it, what they feel, they can now start exhibiting behaviors like violence, you know, and aggression. It's a sort of expression of unmet need. Maybe there's something they need, but they can't find the words to tell you this is what I want. And it can come in that kind of behavior. And then because we don't know, you know, if you don't know, some people may now start thinking of restraints. They start restraining the person, which for me, it's an abuse. It's a human rights abuse. And restraints should not be used. But
from what doctor said is that, from what you said is that sometimes when they don't get what they want, they might exhibit some violent behavior.
Yeah.
Is it not better to restrain that person? And sometimes they just wander about because they cannot remember where they are going to or where they are coming from. Most times they just get lost.
If you show them love, they will calm down. Like I told you, I said I had a personal experience. When he gets like that, what I do is to come to him, close, hold him, face to face. You know, show some concern. Show some concern. Calmly. I know, talk to him calmly, you know, slowly and calmly. Oh, I know what you're going through. What exactly, if he had said a word, maybe he had said something, I want to go home. Sometimes they say they are sitting in their homes and they want to go home. You can pick that word, home. Oh, you want to go home? Where is home? You know, you start talking to that person. Sometimes I find that when I sing, because he likes songs, you know, especially gospel music, then I'll start singing, you know, to him. He calms down. So restraining them with, when I say restraint, I mean putting them in chains.
In chains, okay.
It's an abuse. You don't have to. Or giving them what the medical people will call chemical restraint. They will give them, you know, jab them with a heavy dose of injection just to keep them calm. It can keep them calm, but it can also cause other things, you know. So that is why it is important to have a psychiatrist or a neurologist managing, supervising what they are doing, because they will know what to do.
Unfortunately, we live in a society where people don't want to take such cases to the hospital.
No, they have
this
to.
one don't matter, I bet, make we hide that.
No.
That kind of a thing.
They must, that madness is one word that, you know, that we use and, you know, has negative connotation. If you go to see a doctor, they will not use such words. Those words are bad. They will not tell you. Mental illness comes in different forms. There are different forms of mental illness. It doesn't equate to madness. And a psychiatrist will know what to do, you know, how to manage that particular one or that behavior.
Okay.
And when a psychiatrist cannot do it, he thinks it's a neurological thing. She will, or he or she will refer you to a neurologist. They may work together. This one will be treating this because when it comes, there are so many things that come with it.
Okay.
It's not just one straight linear thing. It's not just one thing. It comes with so many things. So it's a multifaceted, multi-sectoral management that is needed.
Okay, let me come to you now, doctor. How is it diagnosed? Do you just look at somebody and say, oh, this person is suffering from dementia? What's the clinical state of diagnosing it?
Basically clinical.
Okay.
From the symptoms of the illness. Forgetfulness, like I said, that is beyond what you find in ordinary, in people with such age. With aging, people forget normally. But this is beyond that.
Okay, so before somebody starts getting scared, normally people forget things with age.
Yes.
Okay.
For this one, you will know that this is beyond normal forgetfulness.
Beyond the ordinary.
Yes, so it's a clinical finding. Then the type will also determine what kind of clinical symptoms you will find.
Okay.
Because we have different types, and the types depending on the causes. Like I told you, we have neurodegenerative disorders that cause it. We have the one that is Alzheimer's disease. Alzheimer's disease actually accounts for 60 to 70% of dementias. But it's not all dementias that are Alzheimer's. Okay, so if someone has Alzheimer's disease, there's marked memory loss, there's problems with, there's what we call disinhibition, there's what we call lack of executive functioning, like I just mentioned. You now begin to think that, oh, this is dementia caused by Alzheimer's disease. Then you may have vascular dementias. Oh, there's maybe a history of multiple strokes, transient ischemic attacks. This person actually had a history of high blood pressure. And then there's this progression. Once the dementia starts, the person progresses, deteriorates fast, and then stays at a plateau. We call it stepwise progression. And maintains that plateau for a long time. After a while, deteriorates again. You now begin to think, oh, if the relatives gives you this kind of a pattern, you begin to say, okay, this is also dementia due to vascular disorders. You can have some other ones that is caused by lay body dementias. Maybe there is history of fainting, history of falls, and then there's that background memory problems. Then you now say, okay, probably this is caused by something else. Or maybe there is shaking, maybe what we call Huntington's chorea. You can also say, okay, then, or maybe there is what we call normal pressure hydrocephalus. The illness starts, oh, there's this marked forgetfulness, and the person begins to have urinary incontinence, gait problem, is unable to walk, is shaking. You're now beginning to think, is there a background Parkinson's disease? But there is dementia. Or is there what we call normal pressure hydrocephalus in this person?
What was that normal pressure hydrocephalus that you just talked about?
It's a type of dementia. We call it reversible dementia.
Reversible.
Dementia largely they're irreversible. Fluid usually accumulates in the ventricles. But in this person, maybe because of infections or inflammation, there's more than usual fluid accumulating in the ventricles. So if that is discovered, so it compresses on the brain, causes neuronal death, cell loss in the brain, and then memory problems and this dementia sets in. But if the person now, if the doctor notices that that's the cause, it's just to drain the fluid, and then it's reversible. So those are some of the symptoms. Otherwise, a diagnosis is actually an autopsy, because an autopsy, that's when you can definitively say, oh, this is the type of dementia. Because histopathological findings will give you different proteins that are accumulated in the brain for different dementias. For instance, the one that is accumulated in Alzheimer's disease, we call it amyloid proteins. For lay body, we have what we call alpha-synuclein proteins. For what we call frontotemporal dementias, you have tau proteins. There are different names of proteins. There are histological findings. Oh, they can now say, oh, in retrospect, this is the type of dementia that is present. But otherwise, it doesn't affect treatment, because you're going to manage symptomatically and manage whatever problems that comes around it. Mama was talking about disorientation in time, place, and person. That's a major problem. That's why you see a demented patient will wake up in the night and tell you, I want to go home, I want to go to the office. Because it's disoriented in time. It's disoriented in place. He doesn't know where he is, and even in person, doesn't recognize the children. Okay, so those are some of the things. Then the one Mama was also saying, there's this catastrophic reaction. It's not madness. Okay, when they are taxed beyond what they can bear, you know, they want to say something, they're not able to say it. They want to do something, they are not able to, or your expectations are too high. They have this outburst of anger, outburst of rage. It's called catastrophic reaction. It doesn't kill, they won't harm you. It's just lack of understanding that will make someone to sedate such a patient. And besides, the person is an old man. It's even risky to just go ahead and sedate that kind of a patient. They also do what we call confabulation. They also engage in such behavior. They tell a story just to make up. Because we are asking them, they are trying to remember, they are able to remember. So they make up a story and tell you what didn't happen as if it happened. And if you're not there, you will think it actually happened. And after a while, you say, Papa is lying. Papa is always lying. It's not their fault, it's part of the illness.
So when such a thing happens, how do we approach that person? How do you talk to that person? How do you calm that person down?
Calming the person down, even a frank psychotic patient, they are not the way we see them. I give you an instance. I've seen someone with an outrage, you know, in accident and emergency, and I just come in and I give the person a smile. I say, how are you? I say, doctor, if not be you, I would have killed all these people today. Okay, doctor, wait till you say make I do. Okay, see my hand.
That's true.
And the people were like, how did you talk to him? You know, people will just see people and say, oh, this one is mad, and just attack them. So you talk to them, like she said, you talk to them, you engage the person. Now, if it's beyond control, there are some antipsychotics you can give. They are not too sedative antipsychotics to at least take care of the neurotransmitter issues that the person might have. They actually are amenable to one-on-one talk. When we are talking about the management, basically, the non-pharmacological management is actually very important. Maybe when we get there, we'll talk about this one-on-one talk. Do not isolate them. Social isolation is not good for them.
Very bad.
Okay, so those are some of that.
Okay, let me come to you now, Josephine and Annie. We talked about talking to these people with care, treating them right. You know, let me paint a scenario. Sometimes ago in this Benin, something happened at that popular 5 junction where a woman was burnt to death. You know, there was a mob action that the woman was a witch. Perhaps that woman was suffering from dementia because they said she was like incoherent. She was just talking, you know, saying things. You know, when such a situation happens, how are people supposed to react to such a person? How should people react? How should people treat such a person?
Well, that is why this talking about it is very, very important.
That's creating
awareness. So when you see such people, you already know. You have a vague idea that it may be this dementia that the person is suffering from, not witchcraft. Because I remember the case very well. I think they said the woman said she was coming from London or something.
But the woman
said she was coming from London. And of course, they said, oh, she had gone to London to bewitch somebody, and then daybreak has caught the better. That's why, you know, she's there. And so they will lynch her. And that's not the only one. Many cases all over Nigeria. It's very, very,
Why
very common.
Why is it difficult for people to take care of their elderly ones, particularly when they exhibit one form or the other of dementia?
Even the family members, that's where it starts from. Because the family members will label that person a witch to start with. I told you that I know some people who would lock up their mothers in their boys' quarters. And they don't go there to see what is happening. And the woman is shouting or crying or having hallucinations and fighting with invisible people. So for them, it's a confirmation that she's actually a witch. What happens is that they just neglect that person. They don't even give them food. And you will find that sometimes the people, if they are hungry and they see a mound that they had made, they will think it's yam pottage. They will start eating it. And their families will see it. There are so many families that it has happened in, and until the person would die. and then they'll go and do a very big, befitting burial for that person. Meanwhile,
without even taking care of that
without
person
taking care of at the point of need. But with my experience now, I don't blame them. It is lack of knowledge. It is lack of knowledge. Without knowledge, people suffer.
But one would think that when somebody is exhibiting some kind of funny characters that you do not understand, the first point of call is the doctors. You know?
No, not
because
so.
Of our
Not so.
culture.
Yes.
The matters we're talking about,
Yes.
their culture.
It's
the
called,
culture that we have witchcraft. You know, you believe so much in that.
yes.
So when someone
And then the churches are not helping.
You know what they, yes, you know, some people take their loved ones to doctor. And mind you, not all doctors understand. Not all doctors are psychologists or neurologists. And the doctor may just say, I think you need to go to Uselu. And you know, for us, Uselu is mad people's house. It's a stigmatization. Because the doctor knows that this one he cannot handle. So he has to refer
to the professionals,
to the specialist. To the specialist. So he says, I think you need to go and see somebody at Uselu. So because he has said that, the family says mama or papa has gone mad. So, and they do not want their neighbors to know that their parents are mad. So they will start hiding the parents. They will not even want to be seen at that Uselu. So they will start hiding the parents. There are some people who would, now do private practice. We now ask the psychiatrist to come to the house, so that, so that people will not see them visiting the clinic at Uselu. It happens like that. So it is education, and when people understand, then they will now start treating, and then they will stop fearing. Fear that if it happened to my mother, there's likelihood that it will happen to me or my child. The fear is there, and the fear is natural. Okay,
but let me just quickly say this. You're watching the program Healthy Living, and we're doing Dementia today. The ladies are really talking. But adventure, you have somebody, or you know somebody who is exhibiting 1, 2, 3, 4, 5, or all of the signs that the ladies have mentioned on the program. Pick your phone, call us, ask questions. Like she said, if you ask questions and get answers, you will be at peace with yourself. You will know what to do. Instead of hiding that person in the boys' quarter or tying that person down, restraining that person, using chains on somebody that you're supposed to show care for. Of course, that would be very wrong. So pick up your phone now, do that call. You might not know what you will get, but just call to get answers so that you know what to do. All right, 052-290-573 is the number to call. We have a psychiatrist in the building. We also have a woman who is so passionate about these people living with dementia. Ask questions. She's got first-hand experience on this, and the psychiatrist who has been in the field treating all of these cases is also in the studio. Call. After the program, don't call me. I'm not a psychiatrist, and I'm learning so much here today, okay? And I'm sure you're learning too. So call and benefit a lot. There's no point in shaming. Let's just stop this shaming thing, okay? You have somebody, you have a sufferer, you're related to a sufferer. You don't want to be associated with this person. The next thing you may hear is that that person has been mobbed somewhere, because they will go out, they will talk. They might even go naked. What's your gain? That's the question you should be asking yourself. All right, doctor, for how long is this illness? Is it a forever thing? Is it something they live with?
It's actually a chronic illness, okay? Like I said, there are some irreversible forms. Apart from that caused by normal pressure, hydrocephalus, there is this other one that can be caused by infections. All those ones may be reversible. But otherwise, it's a lifelong thing, it's a chronic thing. Now, life expectancy, there's no hard and fast rule about it anyway, but studies have shown that Alzheimer's disease, From point of diagnosis, they can still live up to 10 years.
They can still live up to
10 years.
10 years.
Or more.
Proper management or more. That's why I said there's no fast rule about it.
Okay.
If they are properly taken care of, you treat superimposed infections, the person will live. Then for some, it takes, maybe fast progression, like the ones that have multiple strokes. Some parts of the cell death has occurred in the brain because of these multiple strokes.
Doctor, let me hold you a bit there. Hello, caller. Good afternoon.
Good afternoon.
Good afternoon.
Well, thank you for your advocacy program.
Okay, what's your name, please?
My name is Bishop Samson Iloyinekune.
All right, please ask your question.
I really want to appreciate what you are doing there.
Thank you.
The church too also contributing to this problem. Because someone with dementia problem, they force them to do this fasting and prayer.
Okay.
I want it got to us before they send them to the Sacred Hospital. Please, I really want this advocacy to continue. So I want them to speak out here. Because somebody with dementia problem, they say it's demonic. So please, continue this program. God bless you.
Okay. All right. Thank you so much. He's very happy with the program and want the advocacy to go on and on and on.
There's something I want to mention, please.
Okay.
Doctor, do you know some people, instead of going to the doctor,
Yes.
they go to a prayer house or they go to church. And of course, at that prayer house, in most prayer houses, you will see them using these physical restraints that I have talked about. And that is human rights abuse. They should not do that because they will tell you it's evil spirits, or that somebody has done it. So it requires prayers and fasting. Anybody that has dementia needs good food. Good food. Plenty of vegetables.
Yes.
Good food to keep her. They don't need to fast.
Okay, let's quickly take this call. Hello, caller. Good afternoon. Hello? Hello, good afternoon. Hello? Okay. Hello? Okay, you know what? Reduce the audio level on your television set or move away completely from where your TV is. Hello?
Good afternoon.
Good afternoon.
Please, my name is Supervisor.
Okay.
At times I do forget things. Mostly when I see things, I'll be looking for it.
Okay.
Yes.
You want to know if that is dementia? All right, she forget things.
Everybody forgets things. I forget things. Okay. Children forget things. Everybody forgets things. So it's forgetting things is not it's not a diagnosis of dementia. The doctor has already told us that as you're getting older,
You forget things.
it is normal part of aging. You will forget more things. But that's not the kind of forgetfulness we mean. But you see, the type of forgetfulness is not just forgetting where you kept your pen or something. It's forgetting who you are, where you are, where you're going. You know, you forget.
You're just lost. The person is just lost.
Yes, that type of forgetfulness. I think doctors, people should look for a better word for that type of forgetfulness. Because everybody forgets things. Yes.
So, madam, don't be scared, I beg. Hello, caller. Good afternoon. Hello? Hello? All right, while we're waiting for more calls, on 052290573. Hello? Okay, do us a favor. Calling us, reduce the audio level on your television set or move away from where your TV is. Hello, caller. Good afternoon. Hello? All right, while we're waiting for that call. Hello? While we're waiting for the calls to connect, doctor, is this disease hereditary or can you pass it on?
Yeah, a small percentage of it is hereditary. Or not all. For instance,
like how many
Alzheimer's
percent?
Disease, 5% of it is hereditary.
Is hereditary.
So it's not a thing people should be so scared of.
Oh,
That
okay.
when just 5 people out of 100 have the hereditary component, they have the genetic component that can be passed on to generations. But other types of Alzheimer's disease, some of them are highly hereditary, like the one that is caused by prion disease.
Prion?
Yes, it's a kind of protein accumulation also in the brain. But that is very rare, 1 in a million people.
This protein, is it what you take in, or is something that generates out of the body? Because somebody out there will start talking about protein now.
Food, not protein in food.
Okay.
That's what the histopathologists will call it.
Okay.
They are deposits in the brain. Okay. Ideally, we all have them normally in the brain. Amyloid proteins are there. The prion proteins are there, although there are functions in the brain we don't actually know. But they now undergo what we call mutation. Ideally, they are supposed to be degraded. They are supposed to be broken down by what we call proteinases. That's enzymes are breaking down normally. God made a balance.
A balance.
But now, people that have this mutation, they have the kind that cannot be broken down by these enzymes. And so they keep accumulating and eating up the brain cells, so to speak. So that is highly transmissible. That's highly hereditary.
Okay.
Like the one caused by Huntington's disease. Now, there's something we used to call pre-senile and senile dementia. Those terminologies are no more. We know that pre-senile dementias, those that occur early, 45 years, dementias occurring in children, they're highly hereditary. That's why they're starting early. The ones that occur at a later age, from 65 years, that's actually the dividing line.
Okay.
Most of them, they are not hereditary.
All right, let's quickly pick this call. Hello, caller. Good afternoon. Hello? 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 I can hear you. If only you will reduce the audio level on your television set. Hello?
Good afternoon.
Good afternoon. Please tell us your name.
Please, I was
Okay, I will ask your question, please.
I want to call it that my mom, over 5 years now, she can't sleep.
Your mom cannot do what for over 5 years?
Sleep.
She cannot sleep.
Yes. Everything we lost her daughter, and she can't sleep over 5 years now.
She cannot sleep.
Yes.
Apart from sleep, what does she do again? What are the things she cannot do?
She can do the rest of the thing.
But she cannot sleep. Okay, doctor, why can't she sleep?
There are many reasons why people don't sleep. Okay, insomnia has a wide range of causes. It could be psychological causes, it could be medical causes. Okay, someone that cannot sleep, if you go ahead giving the person what we call a benzodiazepines or sleeping pills, you're going to worsen the situation because the person is going to get tolerant and you need to increase the dose until the point is working.
Okay.
So if someone is not sleeping, bring the person to the hospital. We will find out exactly what the likely causes are that's making this person not to sleep. Because it's not normal for someone not to sleep for 5 years.
Okay.
So that will now inform our treatment.
Okay. Hello, caller. Good afternoon. Please tell us your name.
Good afternoon. My name is Saturday.
Austin?
Saturday.
Okay, Saturday. Okay, how are you? Your television, the level is too high. Reduce it.
Yeah.
All right, talk to us now.
Okay.
I cannot hear you. You have been married since 2011, okay?
Yeah. So my wife was last year and the time for so
if you do not reduce the audio level on your television, we will not be able to talk. Hello, caller.
Hello?
Hello.
Hello?
Hello, I can hear you.
Good afternoon.
Good afternoon.
It's me, Adija Ayuba.
All right, can you reduce the level, the volume, turn it down on your TV?
It's okay.
All right. Okay, we are good. What is your name again?
Adija Ayuba.
Okay.
This is the worker from head to hand. I know they speak. They say now depression. I don't treat for treat for faith, especially medicine. At times I take taking that tablet. So please, I want to know.
You want to know if it's dementia?
Okay.
All right, doctor.
Yeah, they've already told you what they think it is. Whether I'm not too sure whether it's correct or not now, but that's what you said. But sleeping problems, yes, is a part of symptoms we have in dementia because of the disorientation in time and place and person. But that someone is not sleeping is not dementia.
Okay.
So it's not dementia. If it was dementia, the people who told you it's depression wouldn't have told you it's depression. Because depression can come actually with problems with sleep, marked problems with sleep, and there are ways to manage it. And again, did you go back to your doctor when you found that you were not sleeping with the tablets you are giving? Because there are doses. It's not everybody that tolerates a high dose, okay? So maybe the doctor started small because he or she is not too sure of how you're going to react. And then it was as you were expected to come back. And when you didn't sleep, you just felt that this doctor does not even know what he or she is doing. So it's good you go back to the doctor. They may increase the dose or add some other things to enhance your sleep.
All right,
Doctor, she said she has depression. She must go back to her doctor. Because depression is a risk factor for dementia.
All right, Iyom, let me ask you this. Let me ask you this question. All right, you have said that a violation of human rights takes place when somebody who is suffering from dementia is restrained, whether with chain or whatever. Now let's look at the issue of wandering, not knowing where to go, not knowing where they are coming from, with the kind of security situation we have in our society today. Don't you think it is very important for families to restrain? We will answer that question after this call. Hello?
Hello?
Yes, good afternoon. Hello? Hello, I can hear you.
Hello?
Hello, good afternoon. Good afternoon. All right, the caller cannot hear me, obviously. All right, I was talking about restraint, and don't you think it's good for one to keep that person? Because, of course, you cannot be going everywhere with that person.
Yeah.
You cannot go everywhere with that person. And that person may just suddenly bolt out of the house without even you knowing. You know, is it not possible to keep that person in check? Not necessarily restraining the person, maybe keep the person in a room and locking the door so that the person does not go wandering about the streets, not know where to go, and eventually you see pictures on air looking for persons who are missing.
No, I keep saying no.
So how do we care for such a person?
You must respect the rights of that person, the personality of that person.
How do you keep the person safe?
Allow me now to talk.
You will talk. I want to know how we keep that person
so
safe.
Allow me to talk. I'm coming there. The person is in a house. Make sure that the house is, you may have to do some readjustments.
Okay.
You know, you have to remodel your house, change some things so that the person can freely move around the house. And if you have a compound, there's no compound that doesn't have a gate.
Okay.
Make sure that the gate is always locked.
Okay.
So that the person does not have an opportunity to go onto the road. If you're living in a flat, you don't lock, you can, if you are going out, you lock your front door. But if you have somebody like that, you cannot leave that person alone. You must have somebody, a carer, somebody caring for that person, looking after that person. So you can go to work, but there must be somebody else in the house so that the idea of locking the person and going away and it's like locking a child. If it were in overseas, you go to jail for that.
Okay.
You can't lock a child and go to work or go to school in a house. Because not everybody has a compound. Some people are living in flats. But you make sure that there is somebody. It's a 24/7 supervisory job. It's a job that you cannot leave that person alone. So that is why it takes a lot of toll on whoever is looking, the family members, emotionally and economically. Now, you have to go and hire somebody to assist you. That's it has economic cost and all that. So you must allow the person to live a comfortable and full life.
Just to add to what Mama is saying, it's what we call environmental modification. You keep your knives, you keep your keys, you keep things that will cause harm to the patient. Now, like she said, if you're living in a flat, you mustn't lock the person in a room. It's dehumanizing to lock somebody in a room.
Yes.
The person can be inside, the person can stay outside at the gate. That's why education is very important. Like she's saying, behavioral problems of dementia patients is not the problem of the patients. It's the problem of the carers. They are the ones
who
that actually suffers it. So that's why carer support and education is very important. You can't see a person that has dementia and just tell the person that, oh, go to a psychiatrist. You have to educate the carers. You have to tell them, because also their expectations are very high. That they've come to the doctor, they are going to have a drug that will cure it. And if it's not curing, if you are not meeting their needs, they get very frustrated. Yes. So in that case, like she said, a compound, the person should be free to move around in a compound. The person shouldn't be locked in a room, okay? Environmental modification is very, very important. That brings us to some of the management, like I said, non-pharmacological.
Okay, let's quickly talk about the management because time is not our friend.
Yes.
In a minute.
Yes, the non-pharmacological management, music therapy, like she said, is very good. If the person has an instrument, give it to the man to play or the woman. You'll be surprised that the person is so happy. Sing, reduce noise, okay? Social interaction, don't isolate, one-on-one talking. It's very helpful to talk to somebody one-on-one.
So it's not all about drugs?
It's not all about drugs anyway, but drugs, again, like I said, reverses the progression by 6 months. Okay. Sorry, reduces the rate of progress by 6 months. It does not reverse the condition.
All right, Iam, Josephine and Nenny, just before we go, what's your say to those who are watching? Let's look at stigmatization.
Dementia is not something we should be ashamed of. Okay. We should not stigmatize people with dementia.
Okay. All right.
We should not stigmatize. Do not stigmatize people with dementia. Dementia is not all about memory loss. There's a lot of things that go with dementia. That is why you must see a doctor. You must see a psychiatrist or a neurologist. Between them, they know how to manage the different causes of the disease. Like I said, it comes with so many symptoms.
Thank you very much, ladies, for being part of the show today. And I want to believe
and dementia is not a normal part of aging.
Some people can grow old
without dementia. You will grow old without having dementia.
Okay.
So it's not that if you are old, you must get dementia. Nothing like that.
All right, I want to believe that you're out there. You've learned quite a number of things on the program, Healthy Living. We'll see you again on Monday. Until then, health is your responsibility. We'll see you. Bye-bye.